Welcome to week number 5. Ooh, week number 5. We're going to talk about some procedures to assist in labor and delivery. These are the common procedures that you might see in and around labor and delivery, not necessarily right on the labor and delivery floor. The first one is called external cephalic version. This is when a baby is not head down. It's either butt down or like kind of a little lopsided in the belly a little bit. As I think I mentioned, at least on the video, very few doctors want to deliver a baby that's not head down. Like if it's butt down, they just don't want to do it. But there's some patients who really want to have a vaginal delivery. They want to avoid a C-section. So they might agree to have this external cephalic version. What that is the doctor will physically try to manipulate the baby and move the baby in the uterus so that it becomes head down. This, when successful, saves the woman from having a C-section. It's, from all reports, not very comfortable, as you can imagine. And sometimes it's successful, but then woman goes home and whoink, the baby flips back around because it's so used to being the other way. So, but when it does work, the patient will avoid having a C-section. I think that's pretty cool. We have to, as nurses in that area, we do have to monitor mom and baby to make sure we got a stable situation from the start. There's some contraindications, obviously placenta issues and stuff like that. We can't, if there's any risk factors at all, it's probably not a good idea to try to manipulate anything, okay? So we'll kind of count those patients out of the possibility for this. There are some risks as well. I mean, we could, in our manipulation, we could kind of damage the placenta. The water could break and the cord could kind of come down before the baby, which is not a good thing. That's a cord prolapse. And like I mentioned, it hurts. It can hurt. There are some doctors who are really good at it. You can look up on YouTube external cephalic version, and you can see different doctors doing it. And sometimes it looks so gentle. I'm like, that's not my experience. Generally, as the nurse in there, usually they're a little bit more, the patients appear to be a little bit more uncomfortable. But we'll give, some doctors will want the mom to have a tocolytic, which is a medication that's going to relax the uterus, which will help so that the baby can move within it. And then if mom is Rh negative, we'll probably do a RhoGAM shot, or make sure she had her RhoGAM shot at the 28-week mark. And just continued monitoring afterwards to make sure both baby and mom tolerate the procedure. Here's your picture. Bishop score. Now the Bishop score, I'm not asking you to memorize what the the APGAR score. All right. Bishop score is a way that we grade the cervix. Inductions are very, very common these days. We're inducing everyone, it seems. Some smart doctor figured out that the cervix has to be favorable for induction in order for the induction to be successful. Basically, we need to have a nice, ripe cervix before we induce, all right? There are different things we can do to ripen the cervix, so we have to figure out that whole thing. So the Bishop score, using these markers, will tell us how ripe the cervix is, bottom line. All right, we're going to look at cervical dilation. How open is the cervix? How thinned out or effaced is the cervix? the consistency of it. Remember the scallop we talked about in the very first? Is the scallop hard or is it nice and mushy, soft? The cervix. Consistency of the cervix. When a woman is either not in labor or really, really early on in labor, oftentimes the cervical opening of the uterus is tipped. The uterus in the belly is this way, and the cervix actually is tipped backwards. So when you go in to do an exam, sometimes you actually have to go way in and then like hook your fingers around because the cervix is actually pointing to the woman's back. It's a weird and rather uncomfortable exam for the patient as well as the examiner. I've hurt my wrist. It's hard to explain how I hurt it in certain. Well, how'd you hurt your wrist? Probably not. We don't want to talk about it. Anyways, as labor progresses, or as the cervix ripens, I guess we say sometimes that cervix goes from pointing backwards to kind of more towards the front, or at least straight down. And how far down is the baby in the pelvis, the station of the presenting part? All right. So each one of these criteria are given a numeric value between 0 and 3. And I'm not asking you to figure out how to do this. Just know that the practitioners are assessing the cervix using this Bishop score. And that's how they look at it. Success rates of inductions are higher if the cervical conditions are favorable. Favorable cervix for induction is 9 or greater for a score, okay? So, woman has to be induced. Maybe she's 42 weeks pregnant, or there's some other reason why she needs to have her baby. She needs to be induced. What are we going to do? Well, we're going to do this Bishop score. Well, how do we need to start this whole process? Is the cervix ripe and ready for picking? If not, then we have to ripen up the cervix, all right? It's very difficult to put the cervix in the paper bag on top of the refrigerator. Anyone do that with bananas? Avocados? We can't do that in this situation. But there are different medications and things we can do to ripen the cervix, all right? It may be all the patient needs, actually, to kick in and have her go into spontaneous labor all on her own. There's mechanical or physical methods of ripening, and then there are chemical, which are medications, all right? The mechanical, basically what that's doing is kind of like stretching open the cervix a little bit, and in doing that, it is interrupting the integrity of the cervix. So it's rattling it up a little bit, and it sets off the body's own natural prostaglandins and whatnot. But it's definitely kind of not ripping, that's a strong word. We'll just say disrupting the seal between the cervix and the amniotic sac. How's that? There's 3 ways in general that we do that. The first one is a balloon catheter. Foley balloon, everyone knows about a Foley balloon, right? When we're putting it into a bladder, we get it in there and then we fill the Foley balloon with like 10 cc's or whatever, and that balloon prevents the catheter from slipping out of the bladder. Well, we're not putting it in the bladder, we're putting it into the cervix. So we're putting it in the vagina, in the cervix, and lining it up so that the balloon is right in the cervical opening. And we push the fluid in, and it literally, it's not comfortable from all reports. It feels like you're being pushed open, I suppose. That's not very comfortable. But it gets things moving, all right? Membrane stripping is doing an exam and kind of like getting in there and kind of literally using your finger to kind of shake things up. That's also not very comfortable. If rupture of membranes is considered a mechanical method, I don't particularly like this one. If the cervix is not really ripe and we need to induce, you rupture membranes, what happens? The time clock starts and we're at higher risk for infection. So it's best to ripen up that cervix and make sure we're gonna like go into labor before we rupture membranes. It just seems to get things on that time type table too soon for my liking. All right, the last one that is an interesting method of physical or mechanical dilation or ripening is called laminaria. Laminaria is a surgically prepared seaweed. When mixed with the, we'll call it juices of a woman's cervix, laminaria is known to swell. In doing so, it is a more mild way of pushing open the cervical opening. Just like the cabbage, just like the different things, how do they know? How do they figure this one out? You know, was a pregnant woman wanting to go into labor, but she decided she was going to take a swim in the ocean, got something little stuck up there, turns out exactly what she needed. I don't know. How do they know these things? If this seaweed dried up, comes in contact with a woman's vaginal mucus or whatever, I don't know, it boggles my mind, but nonetheless, laminaria, it's sushi? Okay, sushi. It's kind of like sushi. Does anyone like sushi? Or I'm sorry about that. So next time you have seaweed in your sushi, it actually almost looks like cervix, really. Where is this? Anyways. Laminaria. Hey, anything to get you to remember. Then we have our chemical methods. All right, these are the medications that we use. The medications, there's a couple of different ones. Misoprostol is probably now one of the more or most common ones that we use. You might hear it called Cytotec. It's actually a medication we use to help with postpartum hemorrhage after delivery. We use it ahead of time. What they do is it's actually a pill. They can give the patient the pill so they can swallow the pill, or most often what they do is they take the pill and they put it up and they kind of tuck it up over near the cervix so that it absorbs right into the cervix. It's a little bit controversial, not really, but if mom is trying to have a vaginal delivery after having had a C-section and somebody gives her this medication, they will be prosecuted to the full extent of the law. It is, no, that's pushing it. It is strictly forbidden to give misoprostol or Cytotec to a patient who has had surgery on her uterus. It increases the risk, it doubles the risk of a uterine rupture, which we don't want to see. When I say doubles the risk, that sounds pretty impressive, doesn't it? So it takes the uterine rupture risk from like 0.0015 to 0.003. So it's still not like major, but it's double, statistically significant because it doubles the risk. Make sense?
What's that thing?
Cytotec?
Yeah.
Causes uterine rupture. Yeah. Then you have your dinoprostones, Cervidil, Prepidil, prostaglandin. Sorry, there should be an S there. What that is the generic or the manufactured form of our own, the prostaglandins that we have in our body, within our cervix, that we start kind of giving off as our cervix is. In fact, I think I talked about it in last week's lecture about the labor beginning, and there's some theories. One of them was prostaglandin, right? So basically, we're trying to give artificial prostaglandins to see if that's going to get things moving. All right. So we've ripened the cervix. Now we can start induction. All right, induction is chemical or mechanical. Sometimes, again, they can break the water at this point. Cervix is ripe, ready to go. They could break the water, and maybe that's all the patient needs to get going on her own. If not, we could probably give her some oxytocin, Pitocin. Remember way back in that fun OB math test you took? Yeah? Mm-hmm. Yeah. And the dosing of Pitocin, that was fun, wasn't it? That's how very specific, this is what it's all about. It's about using this medication to induce labor. And it is so very, very important that we are tightly controlled with the amount we're giving the patient. Hence why there were so many different questions on the quiz, or on that test about that medication, okay? This is OB math, it's this Pitocin. I will say that the rate of induction has increased exponentially in the last 5 years. And most recently, within this last year, somebody's talking about how everyone should have the right to be induced at 39 weeks, which I guess just opens it up to anyone who just is sick of being pregnant. Who's been pregnant before? At 39 weeks, if somebody told you you can not be pregnant in another day or so, you probably would consider taking them up on that offer, right? Yeah. Well, inducing, I think, just messes with nature. That's my opinion, unless there's a medical reason for it. Now, I was 15 days late. All right, I'm done. I think we're done there. Late, so increased risk of different things after that. That's an indication. But an elective induction at 39 weeks, I don't know, just starts messing with stuff that maybe should be just left alone until the 40th week, 41 week, I don't know. That's just my opinion. However, say a woman comes in and says, I want to be induced, and the doctor says, no. She comes in 4 days later, and there's a complication with her baby. Guess what? That doctor's liable. Even though the doctor's the one who's making the it might not have anything to do with the fact that he said no to that induction. Do you see where society is getting a little out of control when it comes to this sort of stuff? So, needless to say, inductions have exponentially increased in numbers. We're a very scheduled society. We want to be in control of our time, and my in-laws are coming on this day. I want to have delivered, showered, the baby bathed, and the molding improved before pictures, whatever. I know. That's kind of how what we're at. Can you tell my opinion on inductions? Well, there's certainly a place for them. I just think sometimes technology and medicine interfere with what should be a natural, healthy process. And maybe we get an increased C-section rate because we're increasing our induction rate.
That's what I was going to ask. Do you have the right to,
request a C-section?
Yeah.
Same deal.
Okay.
Yeah. Mm-hmm. Elective C-sections are a thing because they don't want to ruin their vagina. Vaginal preservation. I've seen it. Reason for induction. Elective. Patient wishes to preserve vagina. Nothing about the big cut in her belly, I guess. She doesn't care about her belly. Anyways, so inductions may be indicated or elective. We can do that Pitocin, we can break the water. I think I mentioned this a couple slides ago or last week. An amniotomy stimulates both chemical, like those prostaglandins and stuff, as well as mechanical. So say we got a water balloon that's between the head pressing on the cervix and the cervix itself. we pop that water balloon and down comes the head pressing on the cervix. That's going to help get things going when they, so amniotomy is kind of a two for one in terms of getting things moving, I guess. But the timetable starts when the water breaks. And what are we going to do when the artificially rupture membranes? We're going to check the fetal heart rate. Indeed, good job. And we're going to note the amount and the color and the odor of the amniotic fluid. Sorry, I just got to do it. And from that point on, we're going to limit exams. We're not going to keep checking the woman. That's just increasing her risk, further increasing her risk of infection. I mentioned all those prostaglandins and cervidils and dinoprostones and stuff. This is just giving you a little more information about those agents, just what they actually consist of, all right? Some women just need a little bit of dose of that, which, and the other women doesn't do much for, but some women just need a whiff of it and they're on their own, okay? I could have eaten the entire factory of Cervidil and nothing would have happened. In fact, jokingly, I had a vial of Pitocin that I made a necklace out of, yes, and it didn't help, but anyway, I'm not bitter. Yeah, so these medications can be used. The oral Cytotec or misoprostol, because it's, I think, a cardiac drug. So taking it orally, some doctors will actually give Cytotec in the office, take the pill in the office, and send them home. The problem with, if you take the Cytotec by mouth, and it like kicks in, and you get a major uterine contractions, like hyperstimulation, you can't get it back once it's in the system, right? If you put it in the vagina up by the cervix, there might be a chance that as it's kind of melting and absorbing, and if we find that it's hyperstimulating things, they might be able to like flush out the vagina or get the remaining part of the pill out so that we can kind of shut things down. But once the pill is swallowed, there's not much we can do. Pitocin has a very short half-life, so we give Pitocin. If we find we're giving too much, we can back off, and it quickly will adjust and slow things down. With these medications, if it's in the hospital, continuous uterine and fetal monitoring, all right? We talked about during a contraction, at the peak of a contraction, what's happening? Decrease oxygenation to the baby, right? So, yes, we want to bring on contractions, but we have to remember that these contractions are affecting the oxygen supply of the baby. Most babies can handle it, but we got to make sure the baby we're dealing with can. So that's why the continuous monitoring for inductions. So if you want a definition of induction, it's the deliberate initiation of uterine contractions to stimulate labor, all right? And we talked about elective versus medically indicated. Elective is 39 weeks or above. If the insurance companies, if the Department of Public Health, if the CME, any regulating agency finds out that a doctor and a hospital did an elective induction before the 39th week, big trouble. Big trouble. Because some people their dates might be slightly off. We're kind of give or take a week or two. So if we're inducing somebody at 38 weeks, and give or take was 2 weeks more, are we actually inducing a 36-weeker who might actually have trouble breathing at birth? So we really have to put a cushion in there because of that reason. No elective inductions before the 39th week. However, if there's a medical indication, that's where the amniocentesis for checking the LS ratio thing comes into play. Maybe mom is really sick. We're managing her, but she's a ticking time bomb. Whatever, whether it's diabetes or hypertension, or maybe she is got some sort of hormone-related cancer that they found when she was pregnant. She refused chemotherapy during pregnancy, but she's really needing to get herself treated for a non-pregnant related issue. So the risks, we got to look at risks, benefits of the induction before 39 weeks. If there is a medical indication, you can do an induction before 39 weeks. If it's like 37 weeks, then they probably would recommend that amniocentesis to make sure the baby can breathe. And then from there, we will make decisions. You know, that changes the risk-benefit ratio, if you will. If baby can't breathe, is it still, do the risks still outweigh the benefits, or, you know, or the other way around?
Would they always do the amniocentesis first?
Nope.
So
No.
if mom's like in really bad shape, there's no other.
Correct. In fact, I took care of a patient with students, this was a long time ago, when I was at St. Francis with students. The patient had, the placenta was just completely trashed. The patient had terrible, terrible hypertension, was quite sick, and her baby was not developing the way it should because the vasospasms, the placenta was just already just pretty much had it. She was 26 weeks, and they induced her. They took that baby at 26 weeks. Yeah. So risk benefit is that the baby had a better chance of surviving on the outside than on the inside. And the baby actually did pretty well. I don't know. I mean, that was 2.5 years ago. So I don't know how, but the whole time I was there with those students, the baby was beating all odds. So. Labor augmentation, slightly different. Mom might come in, she might have ruptured membranes. Maybe she's contracting a little bit, but she's just not really going anywhere. And we have, we're on a timetable, right? We want to get things moving a little bit, and whether it's to decrease the risk of infection or mom's getting tired because she's been doing this contracting but not very much for the last couple of days. Whatever the reason for augmenting the labor, it is basically just giving spontaneous labor a little boost, all right? Augmenting an already process that's already started. Some hospitals, and I will say it's usually the larger hospitals that can accommodate, that have everyone there at all, like all the players there at all times, specifically for the labor and delivery unit. What I'm about to describe is active management of labor. Active management of labor is bringing everyone in for induction, breaking their water, giving them medication to start labor, giving them the epidural because we're blasting out contractions, increasing the Pitocin because the epidural kind of wiped the contractions out, and getting that patient delivered within 12 hours, one way or the other. That's active management of labor. I will keep my opinions about active management of labor to myself, but know that that's what active management of labor is. Artificial rupture membranes is one of the ways that we augment, one of the ways that we might initiate the whole labor process. That looks like a crochet hook in my opinion, right? It's a little bit bigger than a crochet hook. I actually have one. I should bring it in. I'll see if I'll remember to get the keys for the room, and we can have a little show and tell. It's about this long, and there's a little hook on the end. And we literally snag the bag. It's a bag snag. It's a bag snagger. Break the water. What are we gonna do? Check the fetal heart rate. Well, as I mentioned, I don't know, that must be that looks like it is a duplicate slide. Talked about the prostaglandins and the head pressing on the cervix. Checking that. All right, sorry about that. Amnio Infusion. All right, Amnio Infusion, we talked just slightly last week about when we were talking about intrauterine pressure catheters. It's a two-way system there, so we can actually infuse warm saline into the uterus through the intrauterine pressure catheter. Why would we do that? Well, we do that, the main reason is
it the olive thing?
oligohydramnios. Oligohydramnios is like not a whole lot of amniotic fluid, not enough amniotic fluid. And contractions are coming, that umbilical cord is getting pinched off with every time, because there's no cushion around the baby. So they might infuse this warm saline to kind of give a little bit of a cushion around the baby to minimize variable decelerations, and you know.
My patient had that.
Yeah, yeah. There's another reason we might do this, and it's to thin out thick meconium fluid. They're stepping away from that. So the baby passes meconium, that first stool, prior to delivery. So the meconium mixes with the amniotic fluid and it looks like pea soup. I've never, no ham. I've never seen chunks of ham in meconium fluid. Do you like pea soup?
Not anymore.
And I'm telling you, this one, I'm serious. It looks just like pea soup. I'm sorry, but it does. I'll show you a picture in a minute. You won't know. Is it pea soup? Is it meconium fluid? Well, let me tell you, whether it's pea soup or meconium fluid, we don't want a baby breathing that stuff in. So we might dilute it to more of a broth, a pea broth, so that it doesn't get so clogged up, all right? But they're stepping away from that, and I don't see that as much anymore as we used to see it. Nonetheless, vacuum-assisted delivery. This is when maybe mom is either tired or maybe she just needs a little extra help. So while mom is pushing, the practitioner is pulling. We don't use chains as we do in horses and possibly cows. But this is the human version of chains, we'll say. It's a suction cup, basically, that we put on the baby's head. We get the suction strong enough so that it has a good seal and literally pull while mom pushes. We think, what could go wrong with that? It's a harmless suction cup. Well, I don't know, cephalohematoma, subdural hemorrhage. There's plenty of things that could go wrong with it. How about pulling on a head that won't fit? All right, we got some things here. All right, so we started doing this to replace forceps, you know, the big salad tongs. We'll talk about them next. And we thought, oh, this is much safer. Well, we were in our excitement to have this newer technology, we were putting too much suction. So it was too strong on the baby's head. And we were causing hematomas and subdural hemorrhages, all right? We kept doing it and ignoring the signs that it was causing trouble. You put it on, the doctor pulls on it and it keeps popping off. Well, you have 3 chances now, based on our experience and stuff. You have 3 chances, and if it keeps popping off, that is the world telling you that the head is not where it's supposed to be. If you had it on correctly, if the part of the head we were wanting to come through was there and you were attaching it to that spot, it wouldn't be popping off that way. So 3 chances, 3 pop-offs we call it, and then that's it. All right, so the amount of suction is very regulated, very documented. Releasing the suction between contractions, also regulated and documented. 3 pop-offs, and then if you can't get the baby out with all of those things, it wasn't meant to be. If mom can't push and the practitioner can't pull, the kid's not coming out that way. And we find another method of delivery, like C-section. All right? Scalp laceration, subdural hematomas, cephalohematomas, maternal lacerations. It's a foreign body going up in there, and it could damage things. All right? I will say that my twin sister was vacuum extracted out of my mom. Mm-hmm. So I guess they've been around at least 25 years. It's not that funny. Who laughed like that? That was Katie, right? Katie. It's not funny at all. Okay, 50 years, but whatever.
Numbers, because your daughter's what,
26, that's not the point. I was a very young mother.
2.
-1. 50 years ago at Yale New Haven, they had some sort of vacuum extractor, probably metal and reusable. but anyways, mom's uterus was just too big. That's another good reason. Her contractions and her pushing, she couldn't because her uterus was so big. And she was also in shock because she didn't know she was having twins until just before she was in labor. Whatever. She's not over it yet. Sorry, Mom, if you're watching.
She's not bitter.
She's not bitter at all. Anyway, she could not push that troublemaker of a sister out of her. So they pulled Susie out, and then I, with not giving my mother a bit of trouble, came out gently following that 6 minutes later. So there's your picture. It's got its issues, it's got its risks, but it's certainly had its benefits too. I've seen it successfully done on a number of deliveries. It's certainly preferred over forceps. We'll talk about forceps next. Forceps. These forceps have not changed. I guess they found out what works, and they have not changed in years. You could have 50 years ago the same set of forceps, the same exact design, everything. They really haven't changed much at all. They're very barbaric. Since the beginning of time, they have not changed. I don't know. That might be pushing it, but yeah, they're big metal tongs. So the only thing I can think of, go up and around the baby's head, and again, mom is pushing, and they literally pull the baby out that way. Let me show you a picture that is much too gentle looking, but I will show it anyways. When you're shoving big metal tongs into a woman's vagina, there might be injury. Lacerations of the cervix, vagina, the perineum. Injury to the bladder. Certainly injury to the fetus's, or soon-to-be baby's face, right? And I will show you that. This is what they look like. But you know what? When done right, it saves lives, both maternal and newborn lives. All right, so there certainly is a place for them in our practice. How's that for trying to balance out the presentation? No matter what, if we're pulling on something that was not meant to fit out, if we're pulling on a passenger that's not meant to fit out that passage, we're going to get ourselves into a lot of trouble. All right, we're going to pull to the point of no return. And now the baby's stuck, can't get out or back in, all right? So, I don't know. It's a balance that I don't myself want to ever have to make the decision about. We want an empty bladder. We want somebody to have assessed the pelvic opening as well as the size of the baby long before this decision is made. We want to provide gentle traction and a little bit of pulling, but not excessive force, the whole thing. All right? And a lot of doctors will attempt forceps in the C-section room only. So, all right, we have to have this baby. We will try the forceps, but it's going to be in the C-section room because they're going to give it a couple of tugs. Baby's either going to come out great, or the baby's going to say, "Whoo, I don't like that," or "I can't fit," and they go immediately to C-section. But that should tell you something, right? That the doctor refuses to do it anywhere but the C-section room? I don't know. Anyways, tongs, am I right? All right, quick story. I was a student at Yale New Haven Hospital. I guess I was a student, definitely a student. And, somebody can go down to see the delivery. Well, here I go. Down I go, right? So I get into the room. We're already like set up for the delivery. It wasn't like laboring with the patient. I did not know the patient's name. I knew none of the players in the room. I just was basically standing by the curtain, just having walked in the door. Resident attending fellow, I don't know who he was getting out his forceps. Which, whoa, are we having salad in here? What's happening? Wait a minute, I was here for a delivery, not a salad buffet. What are you doing with, what are you doing here? All right, so these tongs go, right? He clicks them in, okay, push. So, woman's pushing. I assume, hoping she has an epidural, I don't know. I blacked out, I'm sure. Anyways, pull, he's starting to pull. He's starting to pull just a little bit more forcefully than I was comfortable with. It was a little like, whoo, whoo. It gets worse. Let me see if I can do this with my cute little outfit. His feet up on the sides of the bed. And he was like this. I was horrified. To the point where I thought he was going to pull out a head and nothing else. This was 30 years ago, folks. 30 years ago, and I'm right now I'm a bit tachypnic, tachycardic, a little sweaty. The entire baby came out, which is nice. To this day, I was just completely horrified, stunned, clearly traumatized, me. And then many years later, I thought, was he joking with me? Could that have been this whole setup? Oh, we're doing a forceps delivery. Let's bring that student down. See what happens there. Little did I know, 30 years later, I'd be talking about it still. I guess he could have been joking, but I don't know. I don't think it's very funny. I'll be the first one to appreciate a joke. That's not it. My gosh. I honestly thought that was going to be a head and only a head.
Has that ever happened?
Not in a live birth. Yeah.
My biggest nightmare.
Yeah, not in a live birth. Well, naturally, but they have used forceps to try to get a baby who has already perished out, and there's been trouble because of decay. Yeah. Anyways, that's much too gentle a picture, and these forceps come down a little bit lower because they have to kind of grab a little bit lower. Why do I know that? Because that's what happens. That's the bruising around the baby's face. Almost every baby born by forceps has that bruise, and that's the least of the problems. Naturally, the baby came out, so that's good. Maybe the baby was in trouble and came out healthier than it would have had they waited longer. Mom may have avoided having a C-section. The balance, though, some babies, when forceps were used more commonly, Some babies have facial nerve palsy, nerve damage from the forceps, and trouble. Anyways. Episiotomy. Episiotomy is the cutting of the perineum to hasten delivery, we'll say. To shorten the second stage of delivery. How's that? So we are going in, and head is coming. Johnny Cash comes in, and doctor or practitioner feels that they need to give the baby a little bit more room, so they make a small cut to give the baby the opening, more room, and the baby comes out quicker. Sometimes they cut to get the vacuum extractor in, or the forceps, because they really need to get this baby out. Because baby's saying, woo-hoo, I need to get out. I'm having trouble here. So there's definitely reasons for it, by all means. There are two thought processes, and one will never convince the other side of it. Some practitioners say a clean, sterile, surgical cut is easier to repair and easier to heal than a jagged, spontaneous, bursting open laceration. The other side says that the cut is most likely going to be deeper and more significant than any spontaneous laceration. I'm not here to judge. Well, no, I'm going to judge, but I'm just not going to share that judging with you at this time. So it's either straight down in the perineum or medial-lateral, they call it. So a midline appease or a medial-lateral appease, which is slightly off to one side or the other. I've seen it more to the right, but maybe it's just the doctors I've worked with. I've also seen it done on an extremely preterm baby. And when I saw that, I'm like, why are you... There's plenty of room. Well, they don't want any stress on that precious, fragile head. So they'll do an episiotomy to make the exit as stress-free as possible for that fragile preterm baby. C-section. Well, it's the operative delivery through the abdomen of the baby. There are plenty of reasons for it. Whether it's elective, whether it's the baby's not fitting out, the baby's not turned right. Sometimes we start in labor and then the baby says, oh, no, I don't like this. Sometimes mom doesn't like it. Sometimes mom, like me, can labor for several days and not get anywhere, and then end up at C-section for that reason. Sometimes there's more than one kid in there. Maybe one is head down, the other one's not, or it's just too risky, whatever. C-section rates in the United States are astronomically high. The more C-sections we have, the more repeat C-sections we have. So there's that. Who's seen a C-section? Yeah, it's pretty. Well, it's a birth. We need to keep that in mind. It is the birth of a baby and needs to be treated as such. It's not just a surgical procedure, but it is the birth of a baby. That's cool. But there's a whole lot more tugging and pulling than a lot of people are used to, right? The opening that they make in the abdomen is only about this long. What they're doing is they're avoiding having to ligate major vessels in the abdomen and whatnot. They also want to mimic the vaginal birth in terms of like squeezing the baby out. But sometimes it seems like there's just not quite enough room. They're really needless to say, that's what that's all about. It's more about the presence of where the blood vessels, major blood vessels are. They're trying to kind of go around them and not have to ligate. Yeah, it's still kind of cool, I would say. Is that everyone's experience that have seen it? We're kind of like, oh gosh. Lots of stuff going on in there, but it's still pretty cool. That's a gentle picture of the C-section for you. There's certainly risks, infection, reactions to the anesthesia, blood clots, hemorrhage, injury to the bladder, all sorts of things. It can certainly increase your risk in future pregnancies, placental abnormalities, as well as limits your options in terms of delivery of subsequent pregnancies, possibly. Mom can certainly have all of these. Pain is a big one. I like, some people these days are like, well, I'm having pain. Well, yeah, you just had a surgery. I don't get that. Like, well, I don't want any pain. Well, then I guess we can keep you under general anesthesia. I don't get, anyways. Pain is a complication, or I don't know, but severe abdominal pain is considered a complication, according to ATI. So are infections and the like. For those who are OR focused and whatnot, you can look at the details of what goes into having a C-section. Several layers to get in, several layers to repair on the way out. There's a vertical incision. It goes basically from the belly button to the pelvic bone. And then there's a horizontal incision. The vertical incision is, they don't do it very often anymore, but it is very quick, very quick. So if you see somebody having had a vertical incision, you can bet it was an absolute emergency to get that baby out. You don't have to worry about major blood vessels and stuff. It's just right in. You can get in very quick time. The horizontal incision heals better, but it takes longer to get in and get the baby out. Now, I talked about the layers, right? So you can have a transverse incision on the outside, but once they get in there, maybe it's not conducive or something's going wrong. They might have to do a vertical incision on the uterus itself. Again, quicker to get in, but there's issues with the vertical incision. A vertical uterine incision does not heal well, plain and simple. A vertical incision on a uterus eliminates the possibility of having a vaginal birth after a C-section, ever, all right? It is completely contraindicated to ever stress that uterus, that uterine muscle that was cut into with a vertical incision.
Say that again. I'm sorry. So they can't have vaginal birth if they had.
They will not allow. I'm not sure that's the right word, but the woman to have a vaginal birth after the C-section with a vertical incision. But some women really want to have a vaginal delivery. So we look at the circumstances. What kind of incision is there? If the woman was with the same doctor or the same hospital or whatever, we're going to have to get an opno, literally a formal opno to find out what kind of incision. We're not taking anybody's word for it. We're not taking a scar on an abdomen's word for it. We need the official op report telling us what kind of incision's on that uterus. That's how important it is, okay? Say a woman had to have a C-section because the baby was breech. She already had one vaginal delivery, her second baby was breech, and they went for a C-section. Now she's pregnant with a third baby. She knows she could do it. She did it before. She wants to have a vaginal birth. She's compared the two. Vaginal birth is preferable to her. She should be able to, right? So we have to make sure that, we're checking off all the boxes to see if she's eligible. The biggest one, as I think I've said already like 4 or 5 times in this conversation, is the kind of incision, all right? Transverse horizontal incision means there's a chance she can. Vertical incision, absolutely no chance, all right? There are other things, like no matter what kind of incision, if she was just 9 months ago that she had this incision, maybe the healing isn't 100% complete yet, you know? There are some patients who have risked their lives and nearly died trying to have a baby. Cephalopelvic disproportion. This baby is slated to be just as big. You really want to try again? Like, your baby got stuck. And do you really want to try again? You know, that might be a pretty focused conversation with the patient to say, maybe probably best and safer for everyone if you have a C-section. Anyways, that's it. All right, we'll take a break.